Going to talk about meaningful use stage 2. Excuse me. Excuse me. Um, last time we talked about stage 1, so if you were with us, you hopefully have an introduction. Um, just a couple of quick things. One, if you have any questions, please feel free to use the Q&A panel, which is on your desktop toolbar, your WebEx toolbar, or you can send me a chat and I will respond to that at the end of the session. And something that we've been testing over the last couple of sessions is unmuting everybody so that we can have a more interactive discussion. And if we have time at the end of the session, I'd be happy to do that again. Before I get started, just wanted to talk about our disclaimer. Nothing that we share with you is intended to be legally binding or prescriptive advice. The information we share is a synthesis of what's available publicly as well as based on best practices and what we see in the field. So with that, I will get started. And before I wrap up, I'll talk very quickly about our next 2 sessions scheduled for next Wednesday and the following Wednesday. So meaningful use, stage 1, which is what we talked about last week, focuses on data capture and sharing. Stage 2, which went into effect in January of this year for eligible professionals and for hospitals and critical access hospitals in October of last year, focuses on advanced clinical processes. And then stage 3, which has been delayed by a year and is scheduled to begin in January 2017, will focus on improved outcomes. For providers to participate in stage 2, they must have participated in stage 1 for 2 or 3 years. The minimum requirement is 2 years, and they must have attested successfully. This stage focuses on advanced clinical processes, which includes health information exchange. You've probably been hearing your IT folks talking about HIEs, and that is what the intention of meaningful use is to move to an environment where health information can be exchanged between different healthcare organizations. This stage also focuses on an enhanced e-prescribing and lab results requirement, and I will talk a little bit about this as I go over the core requirements. And the continuity of care is becoming a common theme across pretty much all initiatives, whether it's meaningful use, whether it's ACOs, whether it's PCMH. This is really the direction that the healthcare industry is moving toward. And so meaningful use stage 2 focuses on this, as well as on increasing patient and family engagement. The ultimate objective, of course, is to improve patient care. As you probably know, the U.S. has the highest healthcare spending in the world, and our outcomes are 37th in the world, even behind countries like Nigeria. So the difference between the structure in meaningful use stage 1 and stage 2 is that in stage 1, there were 13 core measures for eligible professionals and 14 for hospitals and critical access hospitals. In stage 2, there are 17 core measures for eligible professionals and 14 for hospitals and critical access hospitals. The number of menu objectives in stage 1 was higher than in stage 2. The option was 5 out of 10 in stage 1. In stage 2, it's 3 out of 6. And it's important to remember that a lot of the menu objectives from stage 1 have actually now become core objectives for stage 2. So there were a total of 18 measures in stage 1, and in stage 2, there are 20. So the requirements are very much along the lines of what they were for stage 1, which is to adopt or upgrade newly certified EHR. And the certification needs to be specifically for the 2014 edition. So if you have an EHR that was certified for stage 1, there's a very strong likelihood that that certification sunsetted at the end of 2013. So do make sure that the version of EHR you're currently on is certified by the ONC as a 2014 version. Reporting, if you participate in the Medicare program, the first year you can report any 90 days. This does not apply to stage 2 because you cannot attest for stage 2 right off the bat. But I just wanted to put this information on there in case you'd missed our presentation on stage 1. And then beyond the first year, if you're participating in Medicare, you need to attest based on the calendar quarter. It can't be just any 90-day period. Medicaid allows you to report for any 90-day period. 2014 is an exceptional year in the sense that irrespective of what stage of meaningful use you're at or which year you're attesting for, this year you're required to report for 90 days only. And the other big change for meaningful use stage 2 is that the patient portal is required in order for you to be able to meet some of the measures. Meaningful use calculations, I wanted to go over these again because there is still some lack of clarity around what each term means and how to calculate thresholds. So the denominator can either be all unique patients or a subset of unique patients. The numerator is the number of patients who received certain services for which you're recording information, and you calculate the threshold by dividing the numerator by the denominator. Now I'm going to spend the better part of this presentation talking about the objectives. The first one, CPOE, a computerized provider order entry, is not a new objective. This was also in stage 1. The difference, though, is that not only are providers required to use CPOEs for medication orders, but also for laboratory and radiology orders. And unlike in stage 1, the threshold for all three has now been specified. And the threshold for medications has increased. Last year for stage 1, it was 50%. So if you do not already order labs or radiology tests through your EHR, you need to start doing that so that you can meet this measure. E-prescribing, the threshold has increased for this. Record demographics, the threshold has increased for this as well, but otherwise the measure itself is not new. Again, for both the next two measures, vital signs as well as smoking status, the threshold is increased to 80% from 50%. Use clinical decision support. So this measure was also a requirement for stage 1. However, in stage 2, you're required to have 5 clinical decision interventions, and these need to be related to at least 4 of the CQMs that you report on. We've got a lot of questions around what constitutes clinical decision support. So one of the requirements for meaningful use is that your EHR needs to have drug or drug allergy interaction turned on. So that cannot be counted toward this particular measure. Other clinical decision support measures could be if you, like with vitals, for example, if the vitals are out of range, you usually get a red alert, and then you're required to either, especially if it's the BMI, for example, and it's out of range, you are required to put together a BMI plan. Other examples of clinical decision support are in the form of clinical guidelines or protocols, as well as order sets. So anything where you're able to use your EHR to be able to drive part of the care that the patient receives is a clinical decision support rule. Provide patients the ability to view online download and transmit their health information. So this is the measure that requires that you have a portal. And the requirement for this is that 50% of your patients, 50% of your patients should be able to access this information within 4 days. And then at least 5% should be able to download or transmit their health information. What this rule really means is that you need to have a portal where you have at least 50% of your patients registered to use the portal. And out of your patient population, 5% are actively using the portal, not only to be able to download their health information, but active utilization is also defined as being able to schedule appointments and be able to request medication reconciliation. Provide clinical summaries for patients for each office visit. This is not a new measure. Protect electronic health information. So this was also included in stage 1. The difference in stage 2 is that you're required to use a professional entity to be able to do a security risk analysis. The entity can be external to your organization, or if it is somebody from within the organization, then that individual needs to be qualified to be able to do such an analysis. And for this go-round, doing a self-assessment is not acceptable, so this does need to be a very comprehensive security risk analysis. This next measure was menu objective last year. I'm sorry, I keep saying last year, but what I actually mean is stage 1. Incorporate clinical lab test results into your certified EHR system. And the threshold for this is increased to 55%. So not only has it now become a core, but the threshold has also increased. The next one has also moved from a menu objective to a core objective, and this is to generate lists of patients by special conditions. And the intention here is for you to be able to do population management, either based on common conditions or comorbidities. If you are preparing for PCMH, you've probably come across the concept of being able to track patients with multiple complex conditions. And so the objective is for you to be able to improve quality of care by being able to track patients that fall within a specific category of disease that you might be tracking. The next one is to identify patients who should receive reminders. This, you might remember, used to be a menu objective and is now a core objective. The requirements have still, they haven't changed. So 10% of all patients who have had at least 2 visits in the last 2 years you need to track them for this particular measure. Identify patient-specific resources and provide to patients. So this is a variation on patient education that was part of stage 1. The threshold for this remains unchanged. However, it has moved from being a menu objective to being a core objective. Perform medication reconciliation. This has changed a little bit from what it was in stage 1. In stage 1, medication reconciliation was required only for patients who were transitioning into the care of a practice, but in stage 2, medication reconciliation needs to be performed on all patients. A summary of care record for each transition of care or referral also needs to be provided. And this is where you might have heard the term CCD, a continuity of care document, or CCR, which is continuity of care report or record. Needs to be provided for every patient who you're referring out of your practice to the care of a specialist. If you already participate in an HIE, this is a relatively easy measure for you to meet. If not, then this might require some kind of a workflow change at your practice, where you attach a patient summary of care to the referral form that you sent to a specialist. Submit electronic data to immunization registries. So this, if you remember, was a menu objective for stage 1. And for stage 1, you had only been required to test this capability, but you hadn't actually been required to submit data on an ongoing basis. For stage 2, you need to be able to submit data on an ongoing basis, and there are no exclusions to this. So you need to make sure that you've already tested your EHR's capability to communicate with your local state registry. And then this next one is also a new measure, and it is tied in directly with the patient portal, which is to use electronic messaging to communicate with patients. So at least 5% of your patients should actively be using your messaging capability through your portal. The number of menu objectives for stage 2 has decreased from 10 to 6. Submit syndromic surveillance data to public health agencies. The threshold for this has changed compared to stage 1, in that in stage 1 you were only required to demonstrate your EHR's capability to be able to submit this data, but for stage 2 you are actually required to use this on an ongoing basis. If your local public health office does not have the capability to accept electronic syndromic surveillance data, then you might want to consider selecting a different menu objective. The next 2 are new measures. One is to record notes in the patient record, and this is actually a pretty straightforward measure. It's just making sure that providers are actually recording notes in the EHR, which they should have been doing all along anyway. But now there's a threshold to ensure that they are actually using their EHR in a meaningful way. And then the next one is a new objective, which is to make sure to enable access to imaging results. And this would be something similar to what you currently have with the lab interface. But according to this measure, it's not only the ability to provide access to the report, but to the actual image itself. And the image doesn't need to reside within your EHR, but you need to be able to provide a link that will take the user to the image itself. A record patient family health history. So this is also a new objective, and basically the goal here is to be able to start collecting information on direct family members. The next 2 are new measures. One is to report cancer cases to a registry. And again, we've moved past the stage of just doing successful tests. Now these need to be ongoing submissions. And also, you can choose the measure where you're reporting a specific case to a specialized registry. So the way you select CQMs has also changed. For stage 1, you had about 38 CQMs, and you needed to select 3 core and then 3 alternate. And if for some reason you got a 0 denominator for any one of those, you needed to select 3 additional. But that was pretty much it. There were no, the CQMs had not been affiliated with any specific domains. In stage 2, there are 6 domains, and the CQMs that you select have to be from, you can't select CQMs from the same domain, so you do need to select them from different domains. And these are pretty self-explanatory. So that's basically you can. I didn't want to include all the different CQMs because there are a lot of them. They've increased the number of CQMs. I believe there's somewhere around 70 for stage 2. But you are required to also tie in the CQMs that you select with the clinical decision support rules that are now part of the. They've increased the number of clinical support rules that need to be turned on in your EHR to 5, and 4 of them must tie in with the CQMs that you select from these domains. I wanted to just go over our project plan, our optimal project plan recommendations for 2014 one more time, because we do get a lot of questions around, how the different changes that need to be implemented in 2014 should be rolled out. So hopefully you're now at a point where you have either already gone live with 5.8 if you're using NextGen, and have 8.3 in your test database or very close to implementation. Next quarter, upgrade to 8.3 and also begin claims testing with the different, if you use clearinghouses, but definitely with the different pairs. For Q3, our recommendation is to try and achieve meaningful use. Of course, this assumes that you will have implemented a patient portal and that you will have achieved 5% utilization. And then also start training your providers and staff on ICD-10 in Q3. We don't recommend training them too soon because the chances are that they'll probably forget a lot of the stuff you train them on, and you might be required to do a refresher. So it's optimal to train them closer to go live. And then Q4, as of now, there hasn't been a delay in the ICD-10 implementation. That is still scheduled to be October 1st. And then if for some reason you were not able to achieve meaningful use in Q3, you have a makeup quarter in Q4 to attempt to report in the last 90 days of the year. And then these are just some additional resources that I pulled for you to be able to read through. And I've recorded today's session. I've been forgetting to record these sessions in the past, so today I did record this. We'll upload this to our YouTube channel, and you should be able to listen to this presentation again. And we will also be uploading our slides through SlideShare, so you're able to, you should be able to look through the slides. And if you have any questions, you're welcome to email me or Dan, and I'll share our email addresses at the end of the presentation. So next week, we're going to be doing a debrief of HIMSS 2014. Some of our executives were at the conference, and so we have some interesting information to share with you about that. And then the following week, we're going to be talking about value modifiers. Here are our email addresses. If you have any questions, you can either email Dan or myself. I'm Tamina. A lot of you think I'm Megan, but actually I'm Tamina. And yeah, I'm going to look at, I'm going to see if I have any questions, and then we can decide whether it makes sense to open up the forum for discussion. So one of the questions I have is, the question is, you said that there were no excludes for this measure. We're a specialist office and do not give vaccinations. How do we meet this measure? If you do not administer immunizations, you can still claim an exclusion. What I had meant to convey was that the exclusions last year for stage 1, there were a lot more exclusions where you could say, for example, that your test with the local registry was not successful, and you could claim an exclusion based on that. And so those were the kinds of exclusions I was talking about. If you physically do not administer immunizations at your practice, and you can still claim an exclusion. I apologize if that was confusing. Can you go back to the slide with your email, please? Yes. So hopefully you can see that. So I have a question for the AIU program. Are we required to first register on the NLR? I believe you'd asked me this question last week. So there isn't actually an AIU program. AIU is just the first part of the Medicaid attestation process. And all that means is that you are attesting that you've either adopted or implemented or upgraded your EHR program. Okay, so it seems that there might be some confusion around how you're attempting to attest. So your providers all need to be affiliated as a group with the practice that you're going to be attesting for. And you need to demonstrate that at least 30% of the patients that they see are Medi-Cal patients. Based on that, you can then participate in the Medicaid program. I'm thinking that since this question has come up a second time, it might actually be easier if we were to discuss this via email, or I can have, okay, perfect. So yeah, you go ahead and email me, and then either I or one of my colleagues will get back in touch with you, and then, we can discuss this offline. Let me see if there are any other questions. Can you send a copy of the PowerPoint? Yes, so I did mention that we will make this available through SlideShare, so hopefully that should answer that question. The security risk analysis needs to be completed by a professional vendor. So the CMS ruling on this is a little bit vague. They don't actually come right out and say that that's what's required, but it can definitely be inferred from the language that they use for this particular measure. They do recommend that you use a professionally qualified entity to do this analysis, but then they also say that you can use somebody from within your organization who is qualified to do such an analysis, but they don't necessarily specify what that qualification entails. So most of our clients have actually been using outside professional vendors to complete this measure. I have a new provider. 2014 will be his first year participating in meaningful use. Will he be able to choose any 90 days, or does he have to attest by October 1st? So the driving force here will be whether you're attesting for Medicare or Medicaid. If you're attesting for Medicare, and since this is his first year, he can choose any 90-day reporting period, but he will need to attest for stage 1. The important thing to remember is that just because the provider is new to your practice doesn't necessarily mean that that is his or her first year attesting. And we actually experienced this with some of our clients for whom we were doing attestation last month. Providers who join your practice could have already attested for meaningful use at their previous place of employment. So it's important for you to find out whether this is truly somebody's first year attesting, and if not, then even though it may be the first year at your practice, it would still not be considered the first year of attestation. I'm sorry, the question, so this is about the security risk analysis. and about whether this analysis needs to be completed by a professional vendor. And the question is this new for stage 2? And yes, this is new for stage 2. For stage 1, it was acceptable for a practice to do a self-assessment, and that met this measure. But for stage 2, it either needs to be a professional vendor or it needs to be somebody within a practice who's qualified to be able to do a security risk analysis. Can you use a CCD document in place of the PHR? And I'm wondering if you had actually meant to ask if you can use the PHR instead of a CCD, because ultimately you do want to use a CCD. But yes, I mean, if that was your intention, if your intention was to ask whether a CCD can be used in place of a PHR, then the answer is yes. Okay, any other questions? So we have a bit of time, and even though we have more participants today than we had last week, I'm still going to go ahead and unmute everybody and give you a chance to ask your questions. We can either, I'm happy to answer as many as I can, and we can also use this forum to just share knowledge with each other. So give me a second while I unmute you. All right. So I've unmuted everybody, which means we can hear all of you and any noise in the background.
January 15th.
Okay.
I had to call Dr. Shannon's office on this day because that's when they told me to. First come, first served.
All right. So if you want,
they have a count and somebody whoever designated breakfast and lunch.
All right. I think trying to unmute wasn't very successful. So what I'm going to do is, if you want to talk, do you want to raise your hand maybe? And then I can unmute you. Do you want to try that? No? No questions? No discussion? Okay. I'm going to unmute you. All right. Brenda, you're unmuted. You can go ahead and ask your question.
What do you recommend for documentation of the clinical support rules, even for stage 1?
So the optimal documentation for that is to take a screenshot for the reporting that's taken during the reporting period that shows that you have turned on the functionality that you are claiming as your clinical decision support rule. This is something that actually I failed to mention in my presentation. I had talked about this last week, but it's really critical that you maintain a meaningful use audit binder. Even if you never ever get audited, you still should have this binder. It's best practice, just so that in the event that you were to be audited, you don't need to go scrambling for all the reports that you attested with. So if you take these screenshots, you can include them in your binder. Noel, you had a question. I've unmuted you. No?
No, I'm sorry. I think our mouse was still on that. Sorry. We have no other questions.
Okay, all right. Anybody else? Okay, well, it looks like there are no other questions and nothing else to discuss. So we'll wrap this up, and then next week we'll be talking about what went on at HIMSS and share with you some of our observations, the observations of our executives who attended the session. Okay, so I'm sorry, but I'm not able to hear you. Just a second. All right, it looks like you might be having you might not be able to hear me, but no, you're able to talk if you want to. I've unmuted you. Okay, well, it looks like I guess we don't have any other questions, so we'll see you next week. Thanks very much for joining us. Have a good day. Bye-bye.